Dear colleagues, in this talk I will explain and discuss the concept of double-level osteotomy for varus malalignment. One important message at the beginning of my talk is that valgusation osteotomy does not necessarily mean high tibial osteotomy. Some cases will require a femoral correction and other cases will require a double-level osteotomy, which is the topic of this talk. The concept of double-level osteotomy was introduced with the intention to retain joint line obliquity. When talking about joint line obliquity, we first have to talk a little about knee joint orientation. In a normally aligned leg, the distal femur is in slight valgus relative to the mechanical axis and the tibia is in slight varus. In this case, the knee joint line is orientated 3 degrees off the perpendicular. When walking, the leg is adducted about 3 degrees to the midline. Therefore, the joint line is parallel to the ground during walking. The standing alignment changes depending on the distance of the feet. If the feet are apart as wide as the pelvis, the joint line is inclinated by 3 degrees relative to the ground. With the feet together, the joint line is parallel to the ground again. An osteotomy can consequently create an oblique joint line by altering this physiological knee joint orientation. This is an example of a problematic HTO. On the left you can see the deformity analysis with a severe varus deformity of almost 15 degrees with a pathological MPTA and a pathological LDFA. If this deformity is corrected by a single HTO, it will result in a pathological high MPTA of 98 degrees and hence an oblique joint line. On the other hand, if this deformity is corrected with a double-level osteotomy, that means a lateral closing wedge DFO and a medial opening wedge HTO, the LDFA becomes normal and the MPTA is 91 degrees. The joint line in this case should remain normal. Unfortunately, joint line obliquity is not very well defined. One problem is that no consensus exists on how to measure joint line obliquity. Different measurement methods have been described. The most commonly used method is the joint line orientation angle, which is the angle between the joint line and the floor. Another common method is the medial proximal tibial angle, but this angle does not change with posture and does not reflect the true joint orientation. When using the joint line orientation angle, the question remains whether to obtain single leg or double leg stance radiographs, and for double leg stance radiographs the bipedal distance is not defined, which however does influence joint orientation as explained before. The second problem is that the postoperative joint line orientation angle is difficult to predict because of its dependence on posture, soft tissue adaptations and compensatory mechanisms in the hip and ankle joint. On the other hand, the postoperative MPTA can be calculated by planning and is independent of posture, but it is important to know that the change in JLOA is usually less than the change in MPTA. Therefore, the MPTA is only an approximate estimation of joint line obliquity and an oversimplification. Despite these problems, experimental studies have clearly shown that postoperative joint line obliquity after HDO can be problematic. This finite element study found that a joint line obliquity of more than 5 degrees induced excessive shear stress in the tibial articular cartilage, leading to unfavorable mechanical environment, which is potentially detrimental to articular cartilage. In this biomechanical study with human cadaveric knees, a 4 degrees change of joint line obliquity caused significant mediolateral tibiofemoral subluxation, which caused large movements of the tibiofemoral contact pressure across each compartment. Excessive joint line alterations may therefore cause abnormal tibiofemoral joint articulation and chondral or meniscal loading. And also clinical studies have shown an association with joint line obliquity and worse outcome after HTO. In this 10-year follow-up study, an overcorrected MPTA of more than 95 degrees was associated with inferior functional outcome. However, as mentioned before, an MPTA of 95 degrees does not necessarily mean joint line obliquity. In this outcome study, the joint line orientation angle was used, and the authors found that a joint line obliquity of 4 degrees or more showed adverse effects on clinical outcome, and a joint line obliquity of 6 degrees or more was associated with both effects on clinical and radiological outcome, which was progressive joint space narrowing in the medial compartment. This outcome study after HTO used both the MPTA and joint line orientation angle. The authors compared a group of patients with a postoperative MPTA of 95 degrees or less with a group of patients with an MPTA of more than 95 degrees. The main findings were that patients with an MPTA of more than 95 degrees had more valgus overcorrection, a higher joint line obliquity, and a higher rate of joint line obliquity of more than 4 degrees, and lower functional scores. Another interesting finding was that a postoperative MPTA of 95 degrees was calculated as a postoperative joint line obliquity of 3.9 degrees. Based on this study, a cutoff of the MPTA of 95 degrees seems reasonable to predict a problematic joint line obliquity of 4 degrees. This is another interesting outcome study in which the JLOA and MPTA were used. Key findings were that the joint line orientation angle did not change as much as the MPTA, but an MPTA of more than 95 degrees abruptly increased the JLOA and valgus overcorrection. Furthermore, poor clinical outcomes were more evident in excessive MPTA. So this study is another argument to use an MPTA of 95 degrees as a cutoff. So the main indications for a double-level osteotomy is basically if a single-level osteotomy would result in an oblique joint line. And a good estimation for this is if your preoperative planning predicts an MPTA of 95 degrees or more. Another indication is of course a bifocal deformity with also a pathological LDFA, and you should think about a DLO in patients with a severe Varus deformity where you have the possibility to distribute angular correction, because a DLO is actually a good thing for the patient. You have smaller osteotomy gaps and you can perform bone grafting from the distal femur to the proximal tibia, what leads to faster bone healing. You have a lower risk for hinge fractures and you have less difficulties with soft tissue tension. The indication for a double-level osteotomy is quite common in patients with varus malalignment. We have analyzed more than 300 patients and could show that if you want the postoperative MPTA at a maximum of 90 degrees, a double-level osteotomy would be necessary in 63%, and if you use a cutoff of the MPTA of 95 degrees, a double-level osteotomy is still required in 33%. If you perform a DLO, you can expect good clinical outcomes and high patient satisfaction. In this study from Malgröningen, it could be shown that all functional outcome scores significantly increased as early as 6 months after the operation and further increased until final follow-up. All patients stated they would undergo the operation again, and the radiographic parameters were within physiological limits post-operatively. These are our results from Munich. We also found significantly improved functional outcome scores, a very high return to sports rate and a high return to work rate. This is also an interesting study. The authors analyzed a group of patients in which planning of a single HTO predicted a post-operative MPTA of more than 95 degrees. 34 patients were treated with an HTO and another 34 patients with a DLO, and the results showed a significantly lower MPTA after DLO, significantly less joint line obliquity after DLO, a better Lüsholm score after DLO, and less hinge fractures after DLO. So, or in other words, the double-level osteotomy resulted in a physiological joint line orientation, better functional outcome, and less complications. At the end of my talk, just a few words on the principle of planning of a DLO. As with every osteotomy, a thorough deformity analysis is mandatory. The angular correction should be distributed as equally as possible between femur and tibia. The lateral enclosing wedge DFO is simulated first, and the lateral distal femur should not exceed 85 degrees. Next, the HTO is simulated until the desired mechanical axis is achieved, but the MPTA should not exceed 95 degrees. Some would even tend to leave the MPTA below 93 degrees. And if the joint line conversion angle exceeds 4 degrees, adjustment of the correction angle is recommended. So, in summary, an oblique joint line after osteotomy negatively affects outcome. Joint line obliquity is not well defined and difficult to predict preoperatively. An MPTA of 95 degrees or more seems reasonable to predict a problematic joint line obliquity of 4 degrees or more. DLO allows adequate correction even in severe malalignment while maintaining physiological joint angles, and the indications are severe varus malalignment with a bifocal deformity, and if preoperative planning predicts an MPTA of 95 degrees or more. Thank you very much for your attention.